full screen it?
No, that's fine.
Oh, just keep it this way.
Mhm.
Okay. Hi, this is Elliot Fishman, and welcome to CTisus Quiz 119-2023. It's our monthly quiz. I have about 10 cases for you. I've mentioned this before, that every Wednesday I quiz our faculty. The residents and fellows show up. We have a lot of people. Do it on Zoom, and these are some of the cases I've chosen from there. Now, when I quiz people, I show them more images. I've only tried to show 1 or 2 images per case, but let's get going here. So on the first image, patient with right lower quadrant pain. What are you looking at? You're seeing a mass in the right lower quadrant, maybe 4 centimeters. It's soft tissue density that abuts the bowel. It's not obstructing the bowel. It could be arising from the bowel, be it small bowel or colon. It could be a GIST tumor, perhaps. You also always think about lymphoma. Carcinoids are thought, but carcinoids are usually vascular. Now, what else could I be thinking about? And let me look at the coronal image. You can see very nicely the mass here. You could think about, could this be adenopathy like lymphoma? Doesn't look like a Crohn's or inflammatory. It looks like a soft tissue tumor. Could be an implant. It's not vascular. You could think of Castleman's disease, but that's more in the mesentery. Now, unusual tumors that abut bowel, that can simulate tumors, are desmoid tumors. Desmoid fibromatosis, more common in patients who have polyposis syndromes like Gardner's, but can occur without Gardner's. And so when you look at this case, it ended up being desmoid fibromatosis. What a great case. Just I have 2 more slides to show you that these intra-abdominal desmoid tumors are more common in patients with the familial polyposis related cases rather than sporadic desmoid tumors. And also the fact that desmoid tumors are the most common primary tumor of the mesentery. Who knew? Okay, very good. Okay, next case. Incidental adrenal mass. Now, I was quizzing people on a number of strange adrenal tumors that we had in practice, but I wanted for the fellows to show them a real pheo that you don't have to think about, because I showed a bunch of pheos that were atypical. Hypovascular, cystic, and hypovascular. But here's a mass under 2 centimeters, hypervascular, right adrenal gland. That's a pheo. The only other thing it could be is metastasis, maybe from a clear cell renal cell carcinoma. They occasionally can be very vascular, but the kidneys look good here based on what you see. And this was simply a pheochromocytoma. Just a really, really nice example, very vascular, classic pheo. Okay, what about this case? This was also in the adrenal pile. This is a great case from way back when. There's a large bleed. Now, the truth is it could be a retroperitoneal bleed on a patient on anticoagulant therapy. It could be a mass from the pancreas. It could be maybe off the kidney or the adrenal. Now, yoga usually isn't violent. This is not like you are having really violent yoga, but just was coincidental perhaps. So what things can bleed in the adrenal? We talk about myelolipomas. We talk about adenomas. We talk about primary adrenal cortical carcinomas. We talk about metastasis and occasionally unusual vascular tumors. This patient had no history of a primary tumor. You can see the vascularity, and we've said before, once something bleeds, you can obscure the underlying tumor. Look at the size of the bleed. Look at the extent of the bleed. That's really impressive. I would have thought maybe a metastasis or a primary tumor. This patient did go to surgery because of the bleed, and there was a mass found, but it was an adrenal adenoma with intratumoral hemorrhage. That is a wonderful case. That's the largest bleed I've seen from an adenoma, but it's important to recognize that adenomas can indeed bleed. A really, really good example. Okay, another case. 1 centimeter lesion near AP window. It's vascular. It could be a node. Nodes that are vascular. Castleman's disease might be something you think about. Metastatic disease from a neuroendocrine tumor or renal cell carcinoma, something you think about. But what else could it be? Okay, so let me make it easy for you. There's the lesion again. But I'm going to show you a scan the patient had previously in the neck. There's a vascular lesion between the internal external carotid arteries on the left, which is a classic location for carotid body tumor. Carotid body tumors are also known as paragangliomas. Carotid body tumor is nicely shown in this case, sitting right between the two parts of the branching from the common carotid to internal and external, nicely shown. And so we go back to this image. This was also a paraganglioma. Some patients have syndromes with multiple paragangliomas. Again, most paragangliomas I show you are in the abdomen, near the adrenal, near the pancreas, but they could be in the chest, in the mediastinum, could be in the neck. And again, a really nice carotid body tumor. And just a couple comments. Carotid body tumors are the most common paragangliomas within the head and neck region. Okay? A really, really, really nice case. What about this patient? Cough and fever. Is this a mass? Is it inflammatory? Is it a pseudotumor? You look a little bit more, and you realize the mass is very vascular, and there's a feeding vessel right here, or something looks like a vessel. And sure enough, when you look at the next image, there's a feeding vessel off the aorta to this mass. So what is it? Mass in the right lower lung, feeding vessel. It's not an AVM. You can see small feeding vessels to AVMs, obviously, but it doesn't quite look like that. You could see feeding vessels to tumors, but the thing you need to think about most in the lung bases is going to be sequestrations. Sequestration occurs. There's extralobar and intralobar sequestration. Sequestrations are interesting processes. They have systemic blood supplies. They're typically considered congenital. The intralobar, which was the case here, is more common in adults and children. The extralobar are in neonates. It's more common on the left than on the right. This was on the right. With intralobar, they have a systemic arterial supply and pulmonary venous drainage. And I showed you very nicely the systemic arterial supply. And with sequestrations, again, extralobar are typically asymptomatic. Intralobar are symptomatic. And just like this patient had a cough, infection, recurrent pneumonia, are all things you indeed need to think about. So it's a really, really nice case in that regard. And I really do like it. Again, something to think about. Looking for that feeding vessel becomes really critical. Now, I put this case in. It's just a simple case. Patient with palpable mass in the neck and chest pain. Well, the mass in the neck, you could think about nodes. Maybe the patient has a head and neck cancer. Maybe it's lymphoma. Maybe it's esophageal or gastric, and the nodes drain up that way. That's a possibility. And then I showed you 2 scans in the abdomen. There's a mass in the spleen, and the spleen is enlarged, and there's nodes near the porta hepatis. So now you say, what gives you a mass in the neck, lesion in the spleen, nodes in the porta? Put it all together. What you're dealing with is an acute presentation of a patient with B-cell lymphoma. Adenopathy, splenic lesion. The splenic lesion is mass-like and the spleen is large. You could think about infarct, and sometimes infarcts and tumor are hard to separate. Infarcts are usually lower density, very well defined, triangular, and sharply marginated. But this was a nice example of B-cell lymphoma. Another case, anterior mediastinal mass, lymphoma, usually multiple nodes, but could be a big mass. Teratoma, usually calcifications and fat. Thymoma, often eccentric, like this case is. It's not thyroid growing down, there's no vascularity, and I'll tell you the neck was normal. Metastatic disease is always a possibility. You can see it a little bit better here on the coronal and sagittal. And to no surprise to you, this was a thymoma. Okay, let me do another case. Patient with hemoptysis. What do you see? Bronchiectasis and then a cavitary lesion left up a lung with a crescent sign. When you look at the coronals, you see loss of volume in the upper lung zones. Fibrosis, really impressive fibrosis. And you see here the fibrosis, the arteries, the pulmonary arteries are pulled up, cavitary mass left up a lung, crescent sign. So you're saying upper lung, invasive aspergillosis. That's easy. Maybe that's a diagnosis. But then I want more. What's the basis? Could be TB, could be chronic inflammatory disease. But the thing that gives you fibrosis, loss of volume, upper lobe predominance, and commonly has these secondary infections is going to be sarcoidosis with secondary aspergilloma. Just a terrific, terrific case. Sarcoidosis is a great mimicker. Here's a patient with a mass in the right upper lung. There's some infiltration to the right upper lung. There's some stranding by the mass. Maybe it's a lung cancer with lymphatic spread. That's a possibility and a reasonable thought. There's a little bit of nodularity in the right lower lung. There's adenopathy present, which is fairly substantial. Maybe we're dealing with lymphoma with tumor involvement. Maybe a lung cancer. Here it is in the coronal view, the mass, the adenopathy, second mass in the right lower lobe. What are we thinking about? Again, you got to think about lymphoma, you got to think about lung cancer. Patient was younger. You also got to think what else could simulate or mimic this. There is one answer for that. Sarcoidosis. Sarcoid explains the lymphatic spread, it explains the mass, it explains the adenopathy. Sarcoid is a great, great, great mimicker. Okay, let me give you one last bonus case. Cystic mass arising from the pancreas is large with septations, but it's really arising from the region of the pancreatic head. It's not an adenocarcinoma. It could be a serous adenoma, but the septations are thick. IPMN is too large, and then it will be a malignancy. You can see it on the coronal view. Serous adenoma, septations are thick, but it could be a serous adenoma. Here it is again with cinematic rendering, showing you the septations really well. So serous adenoma, what other cystic lesions? Cystic acinar cell, usually more solid component. Mucinous cystic neoplasms are cystic with septations, but it's usually a 40-ish female and it's in the body of the pancreas. Well, guess what? Not always in the body of the pancreas, it can be in the head. This was a patient with an MCN, mucocystic neoplasm of the pancreas with low-grade dysplasia. Just a terrific case, making you think beyond the box. We're Burger King. We're thinking beyond the box. I think it's Burger King. It's somebody. Anyway, that's about 10 plus cases. I hope you enjoy the cases. I hope you learned something. And we hope to see you all through the month on CTisus and on our YouTube channel. And with that, I thank everybody for their attention. And we'll see you next time. Bye, guys.